Hello everyone, welcome back to the Coach's Compound. This is Corbin Cressley coming back to you again with the lower extremity injuries video. If you've seen the upper extremity injuries video, this will be almost the same thing. We're just going to talk about some of the common things that happen to the lower leg, so anything from the hip down to the ankle and foot. And just like the first video that we put out on these upper extremity injuries, this video will also cover some of just the more common injuries that you'll see in the fitness world and in the athletic world. This will be, again, just kind of more of a flyover view of some of the basic anatomy and mechanisms of injury that you'll see with these common pathologies. As always, go check out the more content from the Coach's Compound at the Coach's Compound on social media, Instagram and Facebook, as well as the YouTube channel. You can check myself out at CB Cressley on Instagram and Facebook, as well as YouTube. So stay tuned and hope you learn a lot from this video.
All right, everyone, let's jump right in. We want to start talking here about the lower extremity. And we're going to do our best to see if we can't do this lower extremity a little bit shorter in duration than our upper extremity video was. And I think the main reason we might be able to do that is because, as we spoke about last time, we were talking about the upper body pathology, and especially at the shoulder, the main idea that was thrown out there was that extra range of motion usually limits for less stability. And with a lower amount of stability comes a greater risk for injury. Now you'll see that a lot of these joints here in the lower extremity are really, really stable. And so oftentimes, especially in just a kind of an exercise setting, we won't really typically see a lot of these acute sort of injuries that may be coming from just an extra range of motion at a loose joint like the shoulder. So joints like the hip and especially the ankle, a little bit more stable in regards to as compared to something like the shoulder. So we're going to start off today talking a little bit about more just common muscle strains that I've seen personally, and definitely going to be kind of more on the posterior leg here, the backside. And those are going to be this hamstring group right here. So we have our biceps femoris, our semitendinosus, and semimembranosus. These are the muscles that make up the hamstrings group. And a lot of times you can kind of see these muscles get strained, aka pull. A lot of times you'll see it kind of right here along the musculotendinous junction. Typically the muscle has a lot of strength in its muscle belly. Right there, but here where the muscle becomes a tendon, it gets a little bit weaker. We also have another kind of common area where we'll either see tightness or maybe a strain possibly, and that is in our psoas group. Now, I include the sartorius in this psoas group, but our psoas group kind of essentially incorporates anything that does hip flexion. So sartorius is obviously not a psoas muscle, but it's going to help us accomplish hip flexion. And some of these quad muscles will also help us do that as well. But if we take and pull these muscles here, here's psoas major coming down out of the abdomen and pelvis. I'm going to actually take and hide this side so we can see those muscles a little bit better. Coming out, the psoas group actually attaches to the spine. Let me move that up just a touch so you can see that. They start up here at the spine, your psoas minor, psoas major, and then iliacus. And then these three muscles essentially become the iliopsoas muscle, which is kind of right in this area here, and that femoral is seen in the femoral triangle. And those muscles can also be strained as well. And typically you'll see, athletes, clients with issues completing hip flexion, especially against any sort of resistance. And the same thing back here with the hamstrings. You'll see athletes and clients kind of have problems either bending the knee in flexion or extending the hip a little bit, even though those glutes do play into some of that hip extension. And so that's kind of what the two main groups we'll see commonly strained. Again, you can also see these quadriceps strained. You have your rectus femoris, vastus lateralis, vastus medialis. If I hide this rectus femoris, we'll get to the vastus intermedius, which is right there. Again, the sartorius plays into this. We also have the adductor longus and the pectineus as well. So we've got a lot of muscles here that start maybe in the medial compartment and come to the anterior compartment to join with your rectus femoris muscles. but all of those have a possibility to be strained. Those are just some of the more common ones, especially in the upper leg. If we take a look down here at the lower leg, obviously these are the big ones: the gastrocnemius, medial head, lateral head, and then this kind of Achilles tendon that incorporates also the soleus, and deep up here, the plantaris muscle, the tendon of that muscle as well. Actually, let me hide this. It's a really cool muscle to see. Very small muscle with a really long tendon. So here's our plantaris. It has that little bit of a muscle belly and then a really long tendon. But all of these fold into kind of down here our Achilles tendon, and we can see some strains here as well. Obviously, a lot of times you've probably heard about Achilles tendinitis or tendinosis. That's a pretty classic injury and kind of what you'd think of like your weekend warriors, people who typically are fairly inactive throughout the week just based on their job or whatever they do for a living, and then kind of go out and play sports or do activities recreationally on the weekends, things like that. A lot of times you can have some ruptures in that tendon there. If it's a complete rupture, it's pretty impressive. It's be pretty hard to miss because typically you will get the muscles, the gastrocnemius here, actually rolling up a little bit. So you'd kind of notice a bulge in the skin. I'll add the skin to this so you can see that. You'd kind of see like a bulge up here in the skin, or that muscle even maybe shorter than normal. And honestly, a lot of times it's been described as the sound that the tendon actually makes when it ruptures completely is almost like a gunshot going off, just because there's so much tension built up in this gastroc and soleus, excuse me, as well. So that is obviously one that you're not going to touch if it's completely torn or ruptured. You want to send that off to somebody who specializes in musculoskeletal injuries to get that taken care of. But those are really some of the main things we'll see with muscle strains. The rest of kind of the things, the common injuries we'll see with the lower leg, kind of deal more with the joints or joint capsules or something like that. So we're going to kind of go ahead and take the muscles away. For the most part, we'll add them back if I need them. So we've got kind of just the lower layer of muscles here. And so kind of what we're going to move down to, the hip can certainly have plenty of pathology, but as you can tell, there's a really solid capsule around this hip, and as well as the articulating surface for the hip is really deep as well. So a lot of times you see more of like chronic muscular issues there, or even some kind of bursitis even. So we could have this superficial trochanteric bursa that sits on top of the kind of lateral aspect of that head of the femur, called the greater trochanter. That can get inflamed, definitely, as you'll see later with some IT band friction syndrome. That can become inflamed up here or even down at the knee, but we'll get to that in a second. So typically, the hip won't give us too many problems, save for just being a little bit tight and restricted in range of motion. So, let's see if I can get that way. What we're going to move down to now is the knee itself. So let's take a look at the knee joint very briefly. You can kind of see it. Here's the back side. Really, really interesting joint. Actually has a sesamoid bone in. A sesamoid bone means it's just a free-floating bone. And if I add the connective tissue back, this patella actually sits in the tendon of the quadriceps femoris and the patellar ligament. So the ligament connects bone to bone, the tendon connects bone to muscle. And you can obviously have any sort of tendinitis, be it or inflammation of the tendon or of the ligament. So that is also another common one. We typically see this patellar tendinitis or even a kind of prepatellar bursitis from those athletes who tend to squat with more of a knee forward position, if you will, or squat with the weight more in their toes rather than their heels. Typically in a nice solid squat, you'll see the weight over the heels and kind of what we'll call the knee stacked above the ankle, just like it is here. But instead, if you see, let me draw this with a pen, if you see that knee really shoot out this way, when the athlete goes to squat and the knee ends up being kind of out over top or out in front of the toes as opposed to kind of stacked right here. This is our optimal position for where we want the knee if we drew a line vertically. But if you see that knee really jutting out far, it could be due to a couple different reasons for lack of range of motion, but that's going to really cause us some tendonitis, some irritation here at the maybe the patellar ligament, patellar tendon, or even the bursa here. We also have kind of these reinforcing retinaculum or ligament type structures here on the front of the knee that kind of run in all different directions. So we can obviously have a lot of kind of connective tissue inflammation there around the knee. The next thing we want to get to, we're going to kind of dive behind the patella here and talk about osteochondral defects of the patella. That's a really fancy way of saying basically it's a wearing away of the articular surface of the back of the kneecap. And I'll show you that here. We'll take the connective tissue away because we don't need any of that. I'm going to hide this femur. So what we're looking at, that nice shiny surface you see on the back of the patella, that is our osteochondral surface. Chondral kind of refers to that articulating surface. You see we have the articular surfaces of the femoral condyles here as well. If I can get this to load up, there we go. This is the articular surface of the tibial condyles, and then we have the articular surface of the patella. An osteochondral defect of the patella means that this cartilage here is just kind of flaking away, or basically having chunks taken off it. And so this can happen with long-term degeneration, like an improper movement pattern, like I was talking about that forward knee squat. But these can also happen with an acute blow to the knee. I know personally I probably have a little bit of this going on due to a couple hits, 1 or 2 hits I remember taking back in my high school football playing days. And so that can kind of just create some either loose free-floating bodies or just a little bit of kind of rough edge on the back of that patella. And over time, if either the patella gets kind of off its normal alignment, here I'll bring that femur back and eliminate all this muscle again, that there's a groove here that the patella likes to sit in when it slides up and down as we go through knee flexion and extension. And if that ever gets off center, or the patella maybe rides a little bit more to the lateral side or to the medial side, that'll make that osteochondral defect even worse. And that's when it may even cause pain. And like I said, if it degenerates long enough, they can obviously have pain there, but it can occur if that patella gets off a little bit to the left or the right. A lot of times the athlete will report a little bit of pain or a lot of pain depending on the severity, a lot of times when they move through flexion and extension. So if I'm taking obviously and moving that knee this way or this way, it's going to create that patella is going to go kind of in this general motion here, and that's going to create some chance for that kind of rough edge to catch either on the anywhere up here on the femur as it slides, and that's what will typically produce the pain. I'm going to kind of move now to talk about something I mentioned before, which is IT band syndrome. And this is kind of the last thing we'll talk about at the knee. Like I said, there's plenty more. Don't need the arteries. There's plenty more in the way of connective tissue. We can spend days. You've probably heard of some pretty common connective tissue injuries to the knee. Most commonly, like people say an MCL tear, a meniscal tear, which I will touch on here real quickly after I talk about IT band syndrome, but actually won't spend a whole lot of time talking about like your ACL tears. Here's your PCL, your posterior cruciate ligament. These will definitely pop up in the fitness and sports performance world, but those are definitely things that are typically either managed surgically or with physical therapy, and so I just won't take all the time to kind of dive into those today. If that's something that y'all would like to see, please shoot us some comments. Let us know you'd like to see that, and we'd be happy to kind of dive into the mechanisms and really all the details about these cruciate ligaments and even some of the collateral ligaments that you see over here that can kind of become injured. So while I'm kind of actually here, I'm going to call an audible. Since I've already kind of got some of this connective tissue removed, let's go ahead and look at some meniscal tears. So a lot of times these meniscal tears, we'll kind of show you what these menisci look like here. we'll leave some of that joint surface around. Actually, I'll move the ACL out of the way. Here's our medial meniscus of the knee. You saw me point out the articular surfaces of the tibial condyles earlier. So this is the menisci. This is medial meniscus, and this is the, if it'll let me click on it, the lateral meniscus. These are kind of like half moon-shaped structures. They help deepen. If we kind of go down here to this level, you can see how it deepens there along that edge, the knee joint itself. But a lot of times we can get some sort of tearing or even flaking, typically along that rim. That's tough to see. I'll put it over here as well. You can get any place around that rim, you can get some sort of tear. A lot of times, these sort of injuries come from kind of a twist on a weight-bearing leg. So if this femur twists on the tibia itself, especially when you're kind of planted on that leg or something like that, it can create some kind of shearing force across this kind of edge of the meniscus and cause a tear in it. It can also be insidious, kind of happening over time without really a definitive cause. It can be from, like I said before, an improper flexion or too deep of a flexion at the knee over time that isn't corrected, can also create some degeneration and a little bit of a tear in the meniscus as well. But typically you'll see a lot of pain with knee flexion. You'll see some pain along the joint line itself. And so it's actually this part right here is actually, and it's sometimes they may be even palpable if that meniscus is torn. And also another thing you'll see with this is a lot of kind of posterior knee swelling can happen with this. Obviously swelling most commonly will shoot to that posterior side. If I add the skin here, it'll kind of, if I can get the proper angle on it, it'll shoot to this area back here. And you can obviously get some swelling around the patella as well. And the swelling and edema can come from a lot of different reasons or pathologies in the knee, but the meniscus can produce some of that just based on the damage that happens in there. And a lot of times, like I said, the patient will have pain along the joint line here. The knee may catch, or if you're kind of palpating the joint line as the knee is moved through flexion and extension and some rotation, you may feel like a catch. The athlete, the patient, may report that the knee just kind of gives way every once in a while, which is obviously something that we want to try to avoid. But those are kind of the main signs and symptoms of that. Obviously, again, if it's a true meniscal tear, it's definitely going to be something that needs to be kind of referred out so that some imaging can be done or whatever to determine the extent of that, and then be it surgery or physical therapy or just kind of watchful waiting with the meniscus can be determined from that. But certainly not something, if there's a tear, that us as coaches can really fix immediately. So that's really what we're going to hit on the inside of the knee. I'm going to talk about the IT band really quickly because I think this is kind of a common buzz term, and just want to point it out really and kind of describe what goes wrong. And I know this is fairly common for a lot of people to get some tightness here on the IT band, especially with a lot of squatting and stuff. So this is our intro. This is our tensor fasciae lata muscle, and this is our gluteus maximus. Both of these muscles are going to contribute to the iliotibial tract, or the IT band. You notice that it's literally a band of connective tissue, very tough, very tendinous. If you ever get the honor and pleasure of dissecting a cadaver, this thing is tough. You got to use some pretty strong scissors to be able to cut through this to expose some of this musculature here. And so a lot of times if these muscles get a little dysfunctional, tensor fasciae latae, or the gluteus muscles, gluteus max, gluteus medius, things like that, they can pull this IT band a little bit off kilter. We can create some friction spots in a couple different places. Like I said, either up here at that trochanteric bursa where the muscle is more involved, or we can create it down here at the lateral knee capsule itself. A lot of times the athlete, the patient, will just complain of a lot of tightness anywhere down through this area, but a lot of times it'll show itself up in the knee. Typically with squatting, running, I've even seen some people report that when they go to like change direction in a run or a sprint or something, that'll really bother them out there on the lateral knee. And so that's what we'll typically see with IT band tendinitis, IT band friction syndrome, whatever you'd like to call it. And a lot of times predisposing conditions for that will be what we call genuvarum. which is essentially what most people would call bow-leggedness, or bow-legged position of the leg. So it's kind of this position here. And so that kind of creates more outward force on that IT band at the knee, creates more friction, hence the IT band friction syndrome. You can also, if we have an athlete who we notice is more of a pronator at their feet, and I'll show you what that means here in a second, where we have this nice medial longitudinal arch right here. A lot of times you may see athletes with what we call flat feet, or PES Plainness, meaning that this medial longitudinal arch is now no longer that nice arch shape. It's kind of more flat. That will cause these tibias to kind of shoot down and inward, which then in turn, as we move up this kinetic chain, draw this one more time. So we have PES Plainness, imagine those flat medial longitudinal arches there. Now all of a sudden we have these tibia kind of shooting inward. Now the head of that tibia tends to shoot in this direction, or maybe even in that direction. And now all of a sudden we get some shearing force at the distal end, or the far away end of that tendon, the IT band. And so that's what's going to really create your pain and irritation there. And that's really the main reasons why it would be caused. But again, some improper squatting technique, or just a little extra shear force due to a given movement can cause that to flare up as well. So that's really going to do it for the knee. We've already talked about some of our strains. So in the hamstrings, in the glutes are a possibility, but more commonly you might see it in the hip flexors or the psoas group, iliopsoas group. Definitely could see it in the gastrocnemius soleus, or in the Achilles tendonitis, or Achilles strain. We talked about even some patellar tendonitis here that we could get as well. Also dove kind of into the knee and looked at the meniscus and some of the common anatomy there that's involved with a meniscal tear. And also talked about some of those osteochondral defects, so the back of the patella. So really just kind of want to finish it up with two things here in the lower leg and ankle. One thing that you've definitely heard before, and probably heard of both of these things, medial tibial stress syndrome. You may not have heard of that, but I guarantee you've probably heard of shin splints. If you do any sort of running, or know anyone that does any sort of running, they may have been afflicted with this in their lives. And it is technically called, like I said, medial tibial stress syndrome. A lot of times isn't involved with one acute injury, but our area of pain is along this side of the bone. Typically due to kind of a muscular pulling on the bone itself that creates an inflammation and kind of even more of a chronic or prolonged inflammatory process there. Whoa, that's not what we needed to do. There we go. Rotate that a little bit. This guy doesn't want to work with me today. Okay, so can even have it here on that lateral aspect of the tibia, but more commonly you're going to see it, like I said, in this medial part, just like the name suggests. Just like I said, we can have this pop up from maybe an increase in mileage if somebody's used to running, or if not really running much and then decides to start running a lot. We can have that shin splint kind of pain pop up. It's typically pretty sharp and may even limit the athlete's activity midway through, or get worse after activity's over. Typically, they might see it resolve a little bit as they start to warm up and get moving a little bit, but then after a while, it puts them down and sidelines them from the pain. Again, if we remember the PES Plainness issue that we talked about with IT band friction syndrome, kind of that flat medial longitudinal arch, those people with the flatter arches are also going to be predisposed to some sort of medial tibial stress syndrome, because it just changes the way forces are transmitted from the ground up through our foot and up through that lower leg in the kinetic chain. So definitely a big issue there with the PES Plainness wanting to cause medial tibial stress syndrome. We could also have some people who are just more what we call pronators, meaning they carry more of their weight on the insides of their feet, right in here, and so the forces are kind of follow those arrows. Forces of gravity follow the arrows there, and that's another thing that could cause that medial tibial stress syndrome, aside from, like I said, extra mileage or maybe improper fitting shoes, or just activities that lower leg isn't accustomed to. So that is shin splints, aka medial tibial stress syndrome. One more to cover. We're going to get right into, try to finish up quickly here, lateral ankle sprains. We've got two types of ankle sprain we could have. Lateral ankle sprains, which is going to be a tearing of any one of these tendons here. We could go into the technical names, but really we just need to know that it's really what these are injured right here. Typically those tendons are going to come from the foot turning in this direction. So I maybe like step off a ledge or off a sidewalk or land funny on that ankle, and the ankle turns inward, or it's a motion called inversion. That will really cause those ligaments on the outside to stretch. And obviously, there's not a whole lot of big, bulky muscle mass that supports this joint. And especially when all of our weight is coming down on that ankle, those ligaments here are going to be really suspect to injury, really susceptible to injury. We want to distinguish between lateral ankle sprains and what you'd call, quote unquote, a high ankle sprain, which actually occurs more up here. Let me remove the connective tissue, remove the muscle, all the muscle. So in a high ankle sprain, we're looking at what we call a syndesmotic sprain. Now, a syndesmosis is basically just connective tissue between two longer bones. And so we have the, let me run that back real quick. The syndesmosis that is basically what made up and held together by this interosseous membrane. And so the syndesmosis that we talk about at the ankle is kind of this space here, this joint structure. And when we get a separation right here between the tibia and the fibula, due to a couple different mechanisms, and that spreads in there, that's what we'd call a high ankle sprain. So the joint angle is opened up, and the ligaments that hold that joint together that come across here, as well as that interosseous membrane, get torn and stretched out. And so that's kind of the differentiation there between the high ankle and lateral ankle sprain. So I think that's going to about wrap it up for these pathologies that we'd see here in the lower leg. Like I said, I hope this was helpful and helped just giving you an idea of the visualization of what these injuries may look like and the structures that they're involved with. So if y'all, like I said, like these videos and really get a lot out of them and want to see more on more specific injuries, just let us know in the comments. We'll be happy to tackle those for you. But as always, it's been a pleasure to be with y'all and pass on a little knowledge about these lower extremity injuries. So stay tuned. Follow the Coach's Compound at the Coach's Compound, myself at CB Cressley on social media, and stay tuned for more great content coming soon.